Throughout this month, we've established that rosacea is a condition of barrier failure, and we've mapped out the triggers and debated the ingredients. But there's one more layer of clinical nuance that we need to add. Not all rosacea is the same. The client who only flushes after a glass of wine is in a very different place than the client with persistent redness and papules. They are on the same journey, but at different stops along the way. Today, we are going to explore the Rosacea Progression Model, the 4 clinical stages of this condition. Understanding this model is the final piece of the puzzle, and it allows you to truly customize your approach to meet your client's needs exactly where they are at. And that is where the magic lies. Rosacea is a progressive condition. It typically doesn't appear overnight in the most severe form. It evolves, and as practitioners, we need to be able to identify which stage of evolution we are looking at. Rosacea is even more complex than this. There are many subforms, but for now, this model is widely recognized in dermatology, and it's incredibly helpful in our practice. Here are the 4 clinical stages, or subtypes, if you will. Stage 1 is erythema totalangiectatic rosacea, or ETR. As you can see, it's very difficult to pronounce. Now, this is the flushing and persistent redness stage. Stage 2 is popular pustular rosacea, PPR, and this is the acne rosacea stage with bumps and pimples. Stage 3 is Phymatous rosacea, and this is the thickening of the skin, most commonly on the nose. In stage 4 is ocular rosacea, and this is where rosacea actually starts to affect the eyes. Let's look at each one as a step on a ladder. Stage 1. This is where it almost always begins, and we call this the erythemotelangiectatic rosacea, or ETR, as I mentioned earlier. It is characterized by frequent, prolonged flushing in response to triggers. Over time, this flushing can lead to persistent, fixed redness on the central face, and you may also start to see telangiectasias and cuperos start to form. At this stage, the primary issue is the vascular reactivity. The blood vessels are hyperresponsive and the barrier is compromised, but the inflammation is primarily vascular. Our goal here is all about barrier repair and trigger management. This is where we have the best chance of preventing progression. If a client is in this stage, your focus is 100% on rebuilding the barrier and removing all antagonists, and using the trigger map we discussed this month. This is defense. We are holding the line and preventing the condition from escalating. If the barrier remains compromised and the inflammation continues unchecked, we can progress to stage 2, the popular pustular rosacea, or PPR. This is often mistaken for adult acne, and here we will see all the signs of stage 1, but now we have the addition of inflammatory papules like red bumps and pustules, pus-filled bumps. This is a sign that the immune response has escalated, and it is often linked to that microbial trigger that we discussed, the overgrowth of the Demodex mites. At this stage, our strategy has to evolve. We still need to complete all the barrier repair work of stage 1, but we may now need to introduce targeted actives such as azelaic acid to help manage inflammatory lesions and microbial load. This is a critical distinction. You wouldn't necessarily use azelaic acid on a client who is only in stage 1, but for a client in stage 2, it can be a very effective tool after the barrier has been stabilized. If the inflammation persists for years, it can progress to more advanced stages. Stage 3 is the Phymatous rosacea, and I don't even know if I'm pronouncing that right, but this is characterized by thickening of the skin, resulting in an enlarged, bumpy texture, and most common form is rhinophema, or the enlargement of the nose in layman's terms. This is caused by chronic, uncontrolled inflammation that leads to fibrosis and sebaceous gland hyperplasia. At this point, topical treatments are less effective and the client often requires medical intervention like laser therapy or surgery. Stage 4 is ocular rosacea, and this is when the rosacea affects the eyes, causing them to be red, watery, gritty, and sensitive to light. This can occur at any stage, but this is often missed. It's crucial to ask your rosacea clients about their eyes. If they have these symptoms, they need to be referred to an ophthalmologist as it can lead to serious eye complications if left untreated. So why is this progression model so important? Well, it is because it tells you what to do and when to do it. Your job as a practitioner is to first accurately identify which stage your client is in. Although we cannot diagnose it, it is helpful to understand when to refer, especially if the condition progresses outside of our own scope of practice. And the second is to implement a strategy that not only treats the current symptoms, but also prevents progression to that next stage. For most of us, our greatest impact will be in stage 1 and stage 2, and this is where excellent skin therapy focused on barrier repair and trigger management can truly change the trajectory of this condition for our clients. Know the stages, know your strategy, know when to refer, and you will become a master at managing rosacea. Thanks for watching. Please like, subscribe, and share, and I will see you next week.